So the last talk is by Rashmin Gandhi. He will talk about optic disc pallor and whether it is always neurological or not.
Small correction from my side. It's the last but one talk. We have all anticipated the final thing is the keynote address by Sachin on AI and ophthalmology.
Thank you so much. Thank you, AIOS and the organizers for a very kind invitation. So I'm going to modify my title a little bit to say that what should we do next when we see a patient with a pale disc. So the first thing, I think one of the slides is missed. The important question that we may face is a person who has come for routine checkup for a presbyopic correction, for example, no symptoms or complaints pertaining his vision. And when we look into the fundus, we find that the disc appears pale. So how do we determine whether that pallor that we are looking at is significant, or what should we do next? So one thing which can help is if the patient is carrying any past medical records, and if there the disc appeared different, then you know that what you are seeing now is a new finding and has to be chased. Sometimes, if the optic nerve function tests are normal, pupil is normal, color vision is normal, no abnormality on visual fields, and the past medical records are not available, or they show a very similar picture, then you know that maybe you are dealing with a pale appearing optic disc and not really a optic disc pallor because of a neurological cause. And why that can happen? The appearance of optic nerve can be influenced by the lens status. If patient has a nucleus sclerosis, the disc may appear a little dark. But if the patient has a pseudophakia or a clear lens, there might be an appearance of a bright-looking disc. Same with the examination technique. How bright your ophthalmoscope is also can influence the color of the optic nerve. And of course, as I said, the final confirmation can be from the optic nerve function test. And if all the optic nerve function tests are normal, maybe you can just observe these patients. Occasionally, when you are still in dilemma, OCT can help you. If OCT shows an equivocal or a thinning of the RNFL, you know that maybe that pallor has to be chased. So in nutshell, scenario number one, pale disc, but no problem at all, no visual symptoms, optic nerve function tests are the way to go, and then observation. Now what about the second scenario? This is a hypothetical picture of a 25-year-old male who has a gradual visual loss in the left eye for the last 6 months, and you know that the disc is pale. So now we are looking at a pale disc in the setting of a gradual vision loss. What would you do next? And this slide I have taken from Dr. Naveen Jayakumar, where the second thing, of course, the first important thing is after optic nerve function test, look at the visual fields very carefully. And you know that the affected eye has a generalized reduction of sensitivity or complete wipeout of the visual field. But what is more interesting is you see this supratemporal defect in the right eye. So this patient has a junctional scotoma. Lesion location is optic chiasm. So patient who has gradually progressive loss of vision and a pale disc has to be investigated because there is a progression of vision loss. So the pathology which has caused a pale disc is still there and is progressing and may cause a devastating problem in the other eye as well. This patient turned out to have pituitary adenoma. So pale disc and a progressive loss of vision, apart from compressive lesion, it can be a nutritional or, as Ramesha had shown very beautifully, a type of hereditary optic neuropathies. Case number 3, a little older patient, sudden painless, or not painful loss of vision. She woke up with this visual loss in the morning 4 days ago. And when she presented, this is how her affected eye looked like. So you see that even in an acute phase, not only there is edema, but the disc is already infarcted, or is going to be infarcted. So there is a pallid disc edema. 70-year-old female, painful loss of vision, and pale-looking disc right in an acute phase. You're probably dealing with a sinister variety of ischemic optic neuropathy associated with giant cell arteritis. So appropriate history of whether patient has a migrating polyarthritis, the joint pains, the weight loss, fever, and jaw claudication would help you to determine whether patient has this arthritic ischemic optic neuropathy. ESR, CRP, platelet, and other investigation would help. The other eye, ischemic optic neuropathy, rarely even the non-arthritic ischemic optic neuropathy can have a segmental hyperemia and pallor. So other eye may give you a clue. In non-arthritic anti-ischemic optic neuropathy, other eye will show a disc at risk, a small disc with a small cup, while in an arthritic variety of ischemic optic neuropathy, you will find a normal cup in the other eye. So that's the pale disc with acute loss of vision. The other scenario, which was partly covered by Ambika as well, is the pale disc with blurred disc margins. Your probable causes are compression, raised ICP, and ischemia, and appropriate investigation would help you in these patients. So in nutshell, if you encounter a patient with a pale disc, it can be neurological, but it can be non-neurological as well. What are the steps to determine whether it's neurological or not neurological? First step is to say whether it's really an optic atrophy or just a pale-looking disc. Direct history and examination, common etiologies, imaging versus observation, and laboratory evaluation. Some of the patients you may not be able to explain as to why this patient has a pale looking disc, and these are sort of a list of tests. This is not an exhaustive list. There are many more tests that one may have to do to determine the cause of pale disc. This was covered by Ramesh again. Optic atrophy in young, there are 3 clinical settings. Optic atrophy with generalized white matter disease like adrenoleukodystrophy, seemingly unrelated systemic features like OPA1 gene mutation, or isolated optic atrophy like autosomal dominant recessive or mitochondrial. There are some of these congenitally anomalous discs which can give an appearance of either an elevated disc or a pale disc, and you will have these signs like small disc diameter, absent central cup, or vessels arising from the central apex of the disc, or anomalous loop, and no superficial capillary telangiectasia, which may tell you that you probably are dealing with something which patient is born with. Myelinated nerve fiber can be confused either with a disc edema or a pale-looking disc, and also buried drusen, as you see here. Patient can be either confused as having a disc edema, or the disc also appears pale. But you know that the smaller vessels on the disc margin are very clear. That tells you that there is no true axonal edema. So if you see a patient with a pale disc, first thing is to establish a structural diagnosis. Is there any problem with the optic nerve? And these are the optic nerve function tests that you'll perform. And these are the probable etiologies, like optic nerve function test. The blood vessels in the pale disc can be because of a problem with the blood vessel or the retina, uveitis, or a systemic association. All of this, apart from a neurological cause which we know of, can produce either an elevated disc or a pale disc. I thank you once again.